Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. Karen Anderson, who is both a friend and colleague of mine. I've known Dr. Anderson for quite a while now. She's an active member of the Association of Extremity Nerve Surgeons, and she was also so kind to author a chapter in my textbook, Practical Pain Management for the Lower Extremity Surgeon, that was published in 2015. Dr. Anderson has adopted a technique known as the Scratch-Collapse test and has been teaching this technique for more than 2 decades. Interestingly, she became aware of this test when she herself was a patient and ended up in the office of one of the 2 orthopedists who developed the concept and the test. She tells her very interesting story in this conversation as part of her journey into the utilization of this clinical diagnostic test and how other physicians can perform it and implement this technique into their practices. In my opinion, this is a very important diagnostic test that can be useful in the diagnosis of some very complex and occult peripheral nerve entrapments, especially those that are subclinical in nature. Karen has a great passion for the patient and has become a center of referrals of those patients that just don't get better. She is very bright, and I enjoy learning from her, as I am sure you will. Please enjoy this conversation that I have with Dr. Karen Anderson. Well, good morning or good afternoon, depending on the time zone that we're in. We're in 2 different time zones today. I'm with Dr. Karen Anderson, and Dr. Anderson, thanks so much for taking some time to come on. And we're going to talk about a very interesting diagnostic test, and I think this will be able to augment a lot of the folks that are already have a great interest in peripheral nerve surgery, and subsequently peripheral nerve diagnosis. So Karen, how did you, well, first, before you tell us how you found this test, tell the audience where you're from and what you do, because I'm kind of envious. You're down in a really nice, warm area right now.
Right. Well, I've been practicing in San Diego for 32 years, which I still don't believe. And when I was, in private practice at the very beginning, I was doing surgery and your basic podiatric practice. And then to segue into this test, it's called the Scratch-Collapse test. I was actually injured in a car accident and injured both my arms very badly. And I saw, everybody in town and, your fracture's healed and this is fine and that's fine, but I was not fine.
Okay.
I was basically a chronic pain patient.
All right.
And so, some of my colleagues said, well, when people have a difficult time or difficult case, they send them to John Beck. So why don't you go to John Beck? So I ended up meeting one of the 2 doctors who originated this test. And at the time he had different names for it, like postural reflex test, et cetera. And he's the only one that bothered to look past the sprains, strains, and fractures and say, well, you might have a nerve problem. No one had ever done a nerve conduction because I wasn't really complaining about burning and tingling and things like that. But he did a test to look for weakness. And the Scratch-Collapse test is a peripheral exam that looks for withdrawal reflex or movement away from a non-noxious stimulus and finding a peripheral nerve. So he did that for me, found it in my forearm, the median nerve. And after all the physical therapy failed, he said, well, let's just do a surgical decompression. So we did that, and both hands felt better with one nerve release. I'm like, okay, what is this test that you do on me? Every time I come in, you must teach me this test. Right. And so I went to his office every day for every Thursday, actually, for about a year until I learned how to do it. And then we started lecturing together because he was invited to various specialties and he would talk about this. So I'd help him with the exam and how to teach other doctors how to do this. And it's an integral part of my practice now.
So just to go back to your personal story, then it ended up that you had a compartment or some type of injury to the median nerve that no one really picked up.
Right. It was in the antecubital space. And it turned out I had this, I don't even know which one it was, an errant additional muscle. I had this
Okay.
anatomical variation in my arm, and it wasn't really considered significant
Right.
until he tested. And that was basically creating an entrapment. And he didn't even realize that was the case until he got in there. So, oh, you have this accessory tendon.
All right.
Okay.
And
Yeah.
without that very simple but yet elegant diagnostic test, you would have just kept floating under the radar.
At 32, I wasn't sure I could continue to do my job.
Hmm.
I mean, it
Right.
was potentially devastating.
Right.
And I would have to break during surgeries, got to shake my hands out, and it was really hard for me to like just do the basic things, shoulder pain, neck pain, because it had escalated over 2 years to almost a central nerve kind of sensitivity, not CRPS, but really both hands injured, both hands with the nerve entrapment, and all the compensatory stuff that happened, all of which went away when he fixed the primary problem.
So he only fixed one arm?
Oh, a year later, he had to do the other one,
Yeah,
but
I was going to say, okay.
yeah, but
Right.
but I had a whole year of not hurting
Right.
anymore.
Right. Yeah, no, we see that in the lower extremity. A lot of times you'll decompress one leg and they'll come in and they'll say the other leg is better. And when I first started seeing that, I thought, wow, this is kind of wacky. But then when, the 10th patient, that month tells you that, it's like, well, maybe I'm the one that's wacky and I need to look at this a little bit more. But that's really interesting. Uh, so it was Beck and Jeffrey. Who was the other? Uh,
Bronson.
Bronson, right. So this was about 2009, right?
Actually, this was when he operated on me was 1998.
Wow.
2009 was when he and Dr. McKinnon were writing together. And that's when they
Okay.
started calling it the Scratch-Collapse test. That's when their
Okay.
joint article first came out. But he fixed my problem in 98. And at that time, Jeff had passed away and John was kind of carrying the torch. And he was still, developing it.
Now, it obviously he had been implementing this for a long period of time before it really came onto the literature, which was about that 2009 era,
Right.
right? Okay.
Right. And, what had happened was the evolution of this is that the two of them, orthopedic surgeons, were treating a lot of sports medicine patients. And they were like, well, why, if we're going to say 15 ACL repairs, college and high school athletes, why do 12 of them do really well? Why do we have three failures when the same
Right.
doctors were providing the same diagnostics with the same surgical skills, same procedures? Why did some kids fail? And so this evolved from their looking at their failures. And they both had a background in neurological development, pediatric neuro rehab, those kinds of things. And so they decided after some exam that the missing link was a more detailed exam of the nervous system and specifically reflexive behavior, not subjective things like does this burn, does this tingle,
Right.
whatever. They're looking for reflexive behavior that was outside conscious control, and so they lighted on motor reflexes. And the Scratch-Collapse test utilizes the skin reflex or the withdrawal reflex, because in a baby until the age of 1, if you very gently scratch their skin, they'll withdraw that limb. After the age of 1, they will not do that.
Hmm.
So if you very gently scratch or touch someone or do a little stroke in the area of a suspected nerve inflammation and they withdraw during this exam, they're exhibiting a regressive reflex.
Okay.
Their nervous system is disorganized, which is
Right.
a form of, when it gets really bad, that's a form of dysautonomia. But it can also happen at a very local level. And that's kind of the origin of
Right.
this, is the implementation of this.
So in your writing, you point out that these two orthopedic surgeons they were basically looking at their patients, like you mentioned, and some of them just were unable to heal, and others were, I think you called them injury prone, or they were prone to many, many injuries. And so they were able to make the deduction that there's something wrong with the autonomic nervous system and postural, for lack of a better way to say it, integrity, and that if the nerve is hurt peripherally, and maybe not even hurt to almost like subclinically,
Right.
that it can disturb this process in the brain that affects the ultimate ability to balance well, or help
That's
help us out with that.
Well, you got right on it. So I sometimes refer to this when I'm dealing with the patients as a balance test.
Okay.
And I explain that it's a reflex. So I will just gently tap their knee, do a patellar reflex to get this involuntary extension of the knee. I'll say, see, that's the reflex. And I've tapped the tendon in the same place. Every time I'm going to get the same reflex. Well, now what we're going to do is a nerve reflex. But instead of smacking your nerve with a hammer, like I would your tendon with a hammer, we're just going to poke or scratch. And the reason why that works is because if you have a chronic, maybe subclinical nerve entrapment, you subconsciously know to get off of that, not use it, protect it. So you get these compensatory strategies, protective strategies, and next
Right.
thing you know, your left knee hurts because you're protecting your right ankle,
Right.
or your heel hurts because you're protecting the front of your foot. But if you're doing this before the nerve gets really grossly irritated to the point where it's conscious, if you do this and you successfully compensate, then you're the person with heel pain that actually has a Morton's neuroma.
Right.
You're the person with heel pain that actually has a common peroneal nerve problem
Right.
because you're successfully compensating it. So they were looking for the things that were outside of the complaint.
Right. And that helps you when you're trying to look at these patients globally and you're failing because you're just treating the tip of the iceberg and you're not looking underneath. It's like, what's going on here? This is very elegant stuff. So explain, if you can, a little bit about what goes on with chronic subclinical, maybe neural inflammation or entrapment with the autonomic system and how does that play? Because I thought that was really a very interesting thing where you're talking about it's a little bit different concept when you're mentioning central sensitization, because when we talk about central sensitization, usually we're thinking more in the Cripps world, these overwhelming pain syndromes. But go into that a little bit if you can, because I think that's really interesting.
Well, central sensitization can happen in just a matter of weeks, and it can be on the spectrum, just like everything else, of not very bad and CRPS. And so as soon as there is a central nervous system sensitization, the other limb can be affected. They start exhibiting what looks like a lumbar nerve root compression when actually they don't really have that, just have sensitization. The reflexive behavior is a centrally acting and centrally occurring phenomenon. Your brain is involved in reflexes. Like a patellar tendon reflex occurs at the spinal level, but proprioceptive reflexes occur at the reticular system level. That is brainstem. And it requires input in order to know where you are. Are you upright? Are you about to step off a curb? Are you oriented to gravity? And if you have a nerve impingement, that nerve is not conducting correctly. If it's not conducting correctly, then faulty information is going to your system for balance, the reticular system. And then you start getting higher order coordination complications. So those are the kids that are always injured. They can't recover from things because the central nervous system is responsible not only for incorporating all that information, balance strategies, and motor behavior, but also protective reflexes, also regulation of healing. Autonomic nervous system is how you regulate healing, how you mobilize white blood cells and blood flow. And so even those things don't work. That's one of the reasons when I was still operating, I would do this test before I'd operate on somebody. I'm not going to do that hammer toe procedure until I've sorted out that nerve right next to it. If they failed reflex for that, because I want the autonomics to be intact so that we get blood flow and white blood cell response and all that.
Very interesting. And sometimes if you can get tricked up very easily, especially in a very busy clinic situation where, you're in the belly of the beast and, they come in for one problem and it's just by default, this is my steps for this particular thing. But if they took maybe this one extra step of including this in their physical examination, it might bring this light on that says, oh, wait a second, I might have to look at something else here and figure out maybe this is a symptom of another problem, a compensation, which I think is going to help them from an accuracy of diagnosis, obviously, but improving the outcome. I mean, you're going to get a much better outcome when you figure out what really is going on versus throwing a dart in the dark.
Well, that's a pretty good segue for a brief PowerPoint, if you like, because
yeah, I'd love it.
because I can go through pretty much your checklist. It's almost like you set me up for it.
All right,
so
good deal. All right, see what you can do there.
All right, we're going to do the
This
best
is,
we can with our technical
yeah.
limitations. So let me do share screen here. Okay, can you see my screen?
I'm starting to. There we go. I've got it.
All right. So
You want to
this
put that
is
in the display mode or?
I did. Here we go.
Yeah, there you go.
There we go. All right. So basically, it is called the Scratch-Collapse test, and it is a fairly literal description of what happens. So this is a peripheral nerve exam using these pediatric or primitive reflexes that I was talking about to localize a suspected nerve entrapment, either prior to an elective surgery where you're going to be, screening a patient for risk factors for not healing, or have they already capitulated into what are more sensory findings where there's a nerve problem and you just want to localize it. But primarily and day to day, it's used as part of an overall exam just for heel pain, for forefoot pain, plantar fasciitis, Achilles tendonitis, whatever. I'm going to incorporate this in. So it's been known by several things. Dr. Beck used to refer to this as the pain process. That's what I referred to it in the chapter you were referencing. If you go on YouTube and you do a Scratch-Collapse test, there's, countless videos for it. That top one, by the way, is the one where I really expound on it. And it's a really basic thing. So the idea is that you do a baseline test. The examiner has the patient sitting on an exam table with their feet off the floor. The elbows are tucked in this neutral position, elbows bent, and you just put a little resistance against the patient's hands and then very minimally accelerate just to the point where you can determine that they can keep up. Then you do a light scratch and what must be a non-noxious, non-sharp stimulus to, anatomical structure that you're testing. And if that person has a problem in that area, they're going to have this momentary fail. And we use this for recalcitrant musculoskeletal problems where patients have been seen by other people and not gotten any better, or they've had this problem for a long time, and try to figure out if there's a nerve involved. So
So
if
let me interrupt there because I want to make sure everybody's clear on it as well as myself. If you can go back to that one slide where you're doing the scratch. Now, let's call that the provocation, although it's
yes,
not a painful provocation, but it is a
right.
provocation. Are you trying to put that provocation into the area where you suspect the entrapment or?
No, it's a
Okay.
checklist.
Okay.
So I'm going to go boom, boom, boom. I'm going to start at the common peroneal, for example. I'm going to
Okay.
go come, superficial, deep,
Okay.
sural, posterior tip. I'm going to just do a checklist, and I do it the same way every time.
Okay.
So you do a baseline test where you see if they can meet your resistance. Then you provoke whatever it is that you're testing. So here we did tarsal tunnel, and I just palpate. And in this case, I would palpate like 2 or 3 spots. So go here, go here, go here, down the exam. And then if the patient had that problem, one hand would fold. Okay.
Is it
So
usually, is that usually ipsilateral or contralateral?
it depends.
Okay.
So usually it's ipsilateral. There are 1 or 2 tests that are contralateral.
Okay.
Usually in upper extremity, but there's one in the lower extremity, like for deep peroneal nerve. But it's very, this is where getting used to doing the test a million times, you start with the first step and keep doing it, you'll figure out what the patient's real resistance is.
Okay.
So there's a peripheral exam and a central exam. The peripheral exam is what I just showed you. The central exam, we're not really going to go into a whole lot here. It's kind of outside the day-to-day use of it, but there is a way to look for people who might be closer to something like CRPS or dysautonomia by using a different set of tests. And the YouTube I alluded to has that, but we're going to stick with just the peripheral provocation.
Okay.
It's already been tested. Dr. McKinnon has been working on this for almost 20 years herself, as have her fellows, and it actually compares very favorably to other ways of testing. So for almost 200 patients who had positive nerve conduction, there were also additional tests that you could do for nerve, like Tinel's and neural tension test, and the Scratch-Collapse test comes out very favorably. As I mentioned, you can use it to localize where exactly, and we're going to do either an ultrasound guided nerve block or surgical decompression, because you can literally march along a nerve and determine where it's the most likely to, where it elicits the reflex, and that's where you're going to target treatment. So localization.
So can I interrupt you a second, because I thought your pictures were really very good there, where you were in the clinical with the gentleman sitting there, and then you were provoking the medial aspect of the ankle, presumably the tarsal tunnel. Would you say, all right, I want to see where this nerve is potentially entrapped, because we know the tibial nerve can be entrapped in several areas, as well as its bifurcation, the medial plantar, lateral plantar. Would you start proximally at the distal medial gastroc soleus and then move distally, and like one provocation, and then test the arms, and that's how you would localize it? Or how do you localize or how do you get specific on the entrapment?
So the response is, the reflex is momentary. You only have a few seconds to elicit the response, either pass or fail. And so I usually start at the top of the tarsal tunnel, more by the flexor retinaculum. I don't really go up into the muscle unless I'm a little more suspicious about pathologically tight calf, equinus gait, something that I suspect might be more proximal. And even in the context of including this in your day-to-day exam, you have to limit your range initially for the most likely areas of entrapment.
Okay.
And then move out from there if you're not finding it. But in this area, where I'm poking right now is about the midpoint. And then if they pass, I would still, especially if they have plantar fasciitis, I would definitely go to the portopetus and more onto the medial foot and test there as well.
So one other question comes into mind here. When do you implement this testing in your physical exam? Is this one of the first things you do, or is it after you've got kind of dialed in an idea of kind of what's going on, and then you want to kind of zoom in on that one area of anatomical entrapment?
So I'm going to do a detailed history, because I always find things like, oh, you broke that ankle 6 years ago, and things like that. So I want a detailed history. Then I'm going to do a muscle strength test, dorsiflexion, plantar flexion, every direction.
Okay.
Major and minor groups. And that often points me in the right direction, because I will often find a unilateral weakness.
Mm-hmm.
And that will kind of target me, because you do have to see however many patients you're going to see that day.
Right.
And so if you can zero in on it by looking for motor weakness, that really speeds it up.
Okay. So you've got a pretty good sense of what's going on, and this is now allows you to put the night scope on it, so to speak, and see what's really going on.
Right. And it's very demonstrative to the patients, because they can feel when they fail a muscle test, and they totally feel it when they fail this test, because it's so unfamiliar to people.
Right.
That it's like they don't even know what's coming. So it's not like they can fake it or, try to second guess it. They've never seen it before.
Right.
So it gets to the point very quickly.
Takes that placebo question out pretty quickly.
Yes, it's very hard to fake this test. I mean, I've actually had attorneys ask me to do this kind of screening test, and someone who fails everything is probably not really participating.
Right.
The tendency is to resist when you're asked to resist.
Okay.
All right. So one of the things about this in that vein is number 2. It is a systemized pattern, regardless of the chief complaint. I do it the same way every time.
Okay.
So basically, if we take this and add it to a typical exam, diagnostic imaging, diagnostic injections, and we add this test, we're much more likely to do a comprehensive exam. So I have an abbreviated version of this. I'm going to actually move out of this for a second and scoot down, because this could get really long really fast. Okay. So one of the reasons this exists is because there were problems to solve. Why were we failing? What wasn't working? We have these problems to overcome. Typically, the patient is giving you the chief complaint, and that directs your search. But that's allowing the patient to give you complaint, and you base it only on that. The other problem is that techniques that are used to diagnose are the same for acute and chronic, and that's not appropriate. It ignores, number 3, compensation. You cannot rely on just what the patient is telling you for looking for the problem, because the pain is not necessarily where the problem is, because we compensate our gait.
Okay.
And the other problem is that most musculoskeletal exams ignore the nervous system unless someone is complaining of burning or tingling. Complaint-based medicine is limiting. You're asking the least experienced person in the room to tell you where to look. Okay. And a checklist overcomes bias. So there are wonderful books and references about this. There are various types of tests that are already in mainstream medicine that are checklists, and this is a checklist.
Right.
So you do your physical exam, you do your imaging, you do evoke pain response, like if the Achilles tendon is sore, you're going to palpate that and examine it and all that. But a lot of the time, that's done with an assumption that there's a functioning nervous system, and that is a faulty assumption. So what might you find on a Scratch-Collapse test? Pretty much an entrapment or irritation of any peripheral nerve. And interestingly, it is periodically on the contralateral limb, because someone is so successful at compensating their gait that their symptoms are not where their problem is. So in that, if you're ready for an example of that, I have a video for you that I can share with you.
Absolutely.
All right. So I'm going to move this over here. So this is a patient who was sent to me. She'd been symptomatic for years. She had been seen, had neuroma surgery twice. The second time, supposedly there was a bursa. She would get some relief from that, but then kept getting more and more pain. And she kept getting put into a boot, and then physical therapy that didn't work, etc. Then she had an MRI finally, and it showed this occult fracture of the cuboid. And then she got put into a boot again. So she spent the better part of a year in a cam walker boot and not getting anywhere. And so her physical therapist has sent her over. And so the following, and I'll narrate for you if you can't hear. So can you hear the audio on the video?
No, so go ahead and narrate it for me.
All right. So basically, we're going to start with an exam of the left lower extremity, because we've already targeted where her symptoms are. It's unilateral pain. So I'm going to make a detailed but focused exam here. And this always starts with a baseline test, which I'm going to show you.
And now, a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
So the important part is to have them meet your resistance and then accelerate lightly to see if they can keep up. That's the difference between just shoving somebody's hands together, which is overpowering them, and actually doing the test correctly.
So when you say accelerate, what you're talking about is a slow acceleration where you're just not trying to overcome them.
That's right. And the whole balance test, the whole baseline takes about 3 seconds. Okay. You can't do this forever, because then someone's going to fatigue.
Gotcha.
Now we're going to start the provocation. We're basically going to march down the peroneals and then do, I believe, web space and Searle. That's the deep peroneal. Sural nerve. There she goes.
So you
So that's
just picked up a sural nerve entrapment right there. Is that
that's right.
right?
That is correct.
Go
So
back like 20 seconds and play that again, because I think that really shows a lot. I mean, when you're reading this, it's hard to kind of grasp exactly what you're doing for this provocation, but that video shows quite a bit.
so that's deep peroneal again.
Yep.
And sural. And it was over a large area. I did not isolate an inch here, an inch there. Did the whole distribution of the sural nerve behind the fibula.
Well,
So
once you establish the nerve distribution, then you can get more fancy with your other, your lidocaine mapping and some of these other things. But that really shows that you took out common perineal, you took out deep, and it was pretty evident that it was sural. I mean, you could definitely see that.
well, what I will tell you about this patient is that this is about her fourth visit, because the nervous system being a system, she was in a cam walker boot, she's immobilized. She actually had a superficial peroneal nerve about 2 months before this. I had injected that, did the hydrid release kind of injection. She did really well. The dorsal foot pain went away, the anterior ankle pain went away. She felt like she had better mobility. And then what happened was she started to get very focal pain along the lateral foot. And this is the person who had had a cuboid fracture. So this is often the case where you treat what you find. You trust it, you treat what you find,
Right.
and the patient may get better or they may not. But what it did is it basically took that next one out of the running. So that's 2 months after treating the superficial peroneal nerve that she had failed before. So 2 months later, she's still passing all the peroneals. This is now another layer in the same location.
Now, when
So
you initially checked her out for her superficial perineal, was she also manifesting some sural at that time?
no, she didn't.
Interesting, isn't it?
Yes, and I think it's because we prioritize. There's only so many things that you can cope with at one time and that your
Right.
body's going to do. Like how many times have you heard a patient got their right knee replaced because the left one wasn't bothering them? 9 months later, they're like, "Oh my God, my other knee," And so, you can have simultaneous pathology going on, and one of them is just, barking the loudest.
Well, the reason I asked you that, Karen, is because it's so common in peripheral nerve surgery. I oftentimes will refer to the patients as onions. We'll pull away that first layer. It's real bad. We know it's bad because we can see it, and they'll get better. But all of a sudden, they'll say, "Oh, I've got something other in this other area." Well, there's a lot of neurophysiology that goes on, but these patients can mask themselves.
True, true. And one of the things I remind people is that when you sprained an ankle, broken an ankle, metatarsal fracture, the force that's required to break bone can cause traction injuries on nerve, especially if it's an inversion injury.
Right.
And it can cause, the edema and the fibrosis can entrap a nerve. So it's not, when you break something, the bone is not the only thing involved. And it's hard sometimes to, remind people of the physics of that kind of trauma.
Right. And then the other premise everybody has to remember is it doesn't take a lot to hurt a nerve. It can be a very, like, almost seemingly non-existent injury, and it can be devastating for people.
Absolutely. It's the most sensitive tissue.
Right.
All right. So we did do an ultrasound guided injection. So we did this from 2 planes. So it's a nerve. This one's a little harder to see. The infiltration is right in here. And then we did a little more distal segment, and you can see it really open up right there.
Oh, yeah, very nice.
And so what happened was we then did a post exam. That was to her physical therapist. So we're doing above superficial peroneal, a more proximal segment of the sural nerve. Right at the injection site. And now she can pass that, and then she failed it a minute ago. So that's
So I'm going to jump to one of my questions that I was going to hold to the end because you just got to it right there. So this seems to correlate very well with your diagnostic blocks then as well, right? So
Oh, very much so. Very much so.
is it, I mean, pretty close to 100% if you're blocking the nerve that seems to bother them, and then after you put that block in, that reflex dissipates or disappears?
It does. And additionally, um, their symptoms improve. For example, I sent that patient back to her physical therapist and also off to, she went to a chiropractor as well and did really well with, sorry, I'm trying to get back to the main screen. Oh, here we go. And so she did quite well. Here we go, stop sharing.
I think if you click on that other tab, there you
There
go.
you go.
Yeah,
Stop sharing.
right.
So she did quite well. In fact, she is, still seeing the physical therapist and the chiropractor, and she did have a trauma. Actually, I had images of her MRI as well. She actually had not only evidence of persistent edema in the cuboid, but she had disuse osteoporosis. The radiologist read the report as being marrow edema in every single visible bone in that image, and she'd been in a boot for 6 months. And what's interesting is the MRI shows the structural problem, but as soon as we solved the functional problem, she went back to exercise. She got out of the boot. She went back to doing everything.
Right, right. That's why MRIs are they really can tell you a lot sometimes, and then sometimes they tell you nothing. And people will say, well, why didn't the problem show up on the MRI? And it's because it's just not a sensitive enough test, even though they are fantastic. And that's why, I talked to one of the gentlemen that lectured at the ANS meeting about the S1 imaging combined PET MRI.
Oh, yes.
Yeah. So the radiologists even acknowledged that MRI is really kind of a poor modality because all it can show is morphology or morphology changes. It doesn't tell you where the pain is coming from. And I mean, shoot, you go across the street to the grocery store and you line up 100 people randomly, 55, 60, 70, who knows, are going to have abnormal MRIs, but they don't have a day of pain. So,
yeah. Dr. Beck used to say an MRI will tell you what, but it will not tell you why.
Yeah, exactly. For sure. So is there any particular areas in the lower extremity that seem to be a little bit more blessed by the accuracy of this test or less blessed?
Well, one of the things that happens periodically is that when someone's been lumbering around with this for a long time, they actually have compensatory issues that have resulted in back pain, core weakness, and it's very hard for them without any core stability to pass the basic tests. They look like they failed everything. So one of the reasons I seat people the way I do is because I can put like a little support behind their back. And because this is so sensitive and so subtle that all they have to have is the impression of some support behind them, contact behind their back. And then I'll actually start the test over again. Because if I don't trust the findings, it doesn't jive with their symptoms or gait.
Right.
And I'm going to assume that they've deconditioned or they've got this central nervous sensitization and lumbar spine is weak, given that it provides all the nerves to the lower extremity. So I'll just support that and then, test again. I will say that when patients have any diabetic neuropathy or sensory neuropathy, it's very hard to do the test because they have to perceive the provocation. So this works best in people who do not already have profound sensory loss.
Yeah, that makes a lot of sense for sure.
So there's limitations to every procedure, every exam. This is no different. There are limitations to this as well. There are times where if someone I think is really on the precipice of CRPS, there's no way I'm going to stick a needle in that person. So I'll have them start some gabapentin and I'll do that for a month. I have a very interesting case I want to tell you about that I did reverse CRPS. It was active CRPS, and there's no way I was going to inject that guy until he had his lumbar sympathetic block first.
Right.
So we did that, which kind of, wipes the slate clean for a little bit. It kind of clears some of the, dysautonomia or nerve sensitization for a while. Then I can trust that test. So the weaknesses are really more about the condition as opposed to one individual nerve or another.
Right. Yeah. And I would imagine with somebody with hyperalgesia, anything that touches them is going to fire them off. So it would probably be not a very good test in that situation, because the canvas that you're trying to paint on is not receptive to the paint.
Exactly. But there's
Yeah.
alternatives. So I can make an orthotic correction for that pathology. I can do a transdermal medicated cream if you want to. I can show you a slide about that. So if I'm going to share screen again and show you a few things. If there is an alternative, it would be something like transdermal medicated cream. So if I'm not going to do the lidocaine block, I may do a transdermal medicated cream that has ketoprofen 20% and cortisone 2%, and it's compounded. I have them use just 1/8 of a teaspoon over the area and do a very gentle nerve mobilization kind of massage. I can make orthotics that help these things. We all know that a metatarsal pad helps in Morton's neuroma, so let's just do that and do kind of a flexible device. Let's see if I can advance this. Okay. The pros and cons of this include the fact that it's objective. You're not getting the patient to say, oh, that stings, or oh, that feels better, or that burns. It really only takes a few minutes. I mean, you saw how quickly we could rule out and localize the nerve for the patient in question.
Right.
It does tend to solve pains faster because you're looking at the next system that hasn't been examined. And the special equipment, I mean, if you're going to do an ultrasound guided injection, fine. But because there's things besides injection, like orthotics, transdermal cream, physical therapy, etc., you don't really need any special equipment. It does take a little while to learn, but I've even taught people this remotely. A young lady in Maine read the chapter in your book, and she contacted me. And this is mid-pandemic, and we weren't traveling. And I said, here, I'm going to send you some educational materials about this, some videos. And she really picked up on the whole maneuver. Then we did some Zoom appointments where she would have a patient in front of her. And I would guide her and say, okay, well, evoke here and do it here. And I could even observe how she did the resistance test. And she now knows how to do it. And she'd been doing it a year before we ever met. We eventually finally got to work together. So while there's a learning curve, not only is it possible, but it's even possible remotely. I tell people it's a skill, not a pill, so it takes a little bit of work. And the research on it, it's so new that the research is a little limited because someone is not necessarily trained. I read one paper where a group of residents were brought into the room to do this test, and they found it to be meritless. Well, it's because it was unpredictable results.
Right.
But it was probably unpredictably applied. You would never have someone, come in from a clinic and say, here, try this surgery.
Right.
Do surgery first.
Right.
So, I take issue sometimes with a poorly applied technique, but when it's applied, it's pretty amazing. I have, a couple other examples, pre and post injection too.
Let's see them, because I think these examples are really they're illustrative of the whole concept.
All right, so I meant to get to my screen here. Oops. Okay, so I do neural tension tests of a sort, and this is really important. The reason why some of these tests work is the concept of inhibition. Dr. Beck and Dr. Bronson identified weakness. Weakness is a symptom, not just pain, not just limping. Weakness is a symptom. And sometimes what happens is patients avoid movement or tension on an area. And when you find it by doing this test and block it, their strength comes back. So that's what this is about. And if you can't hear it, let me know and I'll narrate.
Okay. Yeah, go ahead and narrate for us if you would, Karen.
So this is a neural tension test for Morton's neuroma. And what happens is the nerve is plantar. And in a position where hyperextension like this, there's tension on the plantar nerve. And for some people, that's so irritating, they can't maintain that position. So there's the affected foot and the unaffected foot. And when I stop talking, I'll actually show you. I'll advance this a little bit. So she can do the test here. Okay, she can resist that. She can't. So now, at times one would say, oh, that must be peroneal because it looks like motor weakness. But motor weakness is also inhibition. And what's inhibiting her is the plantar nerve. It's so irritated being extended like that that she folds to a place of relaxation. So the misconception is motor nerve function. This is proprioceptive and sensory nerve function. And the reflexes are, in this case, 180 degrees. So here's what we're going to do. I'd already done the scratch collapse. I'd already ascertained that it was Morton's neuroma in the third space. So we're going to do a little block with a little cortisone. And we can take advantage of the quick acting lidocaine, 1 or 2%. And it's really small quantities. I mean, I tell my employees, fill up a 0.2, 0.2, 0.2. So I'm going to do lidocaine, 0.5% marcaine, and a wee bit of Kenalog 10 or 40, depending on where I'm at. This can take a Kenalog 40.
So let me ask you a question because I want to be clear on this. Before you put that right foot into the tension position,
yes,
she had more ability to fight plantar flexion of her digits or not?
If I didn't test that one, but routinely what will happen when a patient is sitting in these exam chairs, hamstrings are straight, calf is straight, they're in a position of some degree of tension or lumbar strain. For some people, not all, if they fail that test, I'll swing their legs over the side and take the strain off their back, take the strain off of the knee,
right,
and test again. Sometimes that will be yay or nay, like it'll be worse when they're extended and better when they're flexed. But usually if their back or their knee is involved.
Okay, so from my understanding, you're not necessarily seeing, because I would presume that if I had somebody with a hot third inner space and I make it more hot with the tensioning, that would even be more of a there would be more inhibitory effect going on. Do you see that, or am I just trying to bark up the wrong tree?
Context matters. So in this position, when on the left foot she could do it and the right she couldn't, I'm willing to accept that as this is the problem. And it actually just confirmed the scratch collapse test I did a few minutes before.
Okay. All right.
So I've already done the injection. There's local, and the 1% works pretty quickly. I'm futzing to give the local some time.
Gotcha.
So now we're going to repeat the study. So there she is doing it on the asymptomatic foot. And now she can resist. Because her brain doesn't think there's a problem there because it's numbed.
Right. Okay? And that clearly has nothing to do with common perineal.
Correct.
Well, let me rephrase that. It does from an inhibitory status, but it doesn't from a
motor
status. Right.
Right. And that, there's just so many examples. I even get surprised sometimes, as I said, the nervous system is a system. And as you said, you're peeling the layers of the onion. So sometimes you'll block A and then they'll have the patient walk, for example. And after this, I'd say, okay, well, let's have you walk in. Okay, my heel pain is 50% better. Well, I may take out the ultrasound, look at the plantar fascia and say, okay, well, you have two problems. You have the plantar fasciitis, which is your chief complaint. You failed the nerve test, so I block that, and you're 50% better. The ultrasound shows a lot of fibrosis, possibly edema in the plantar fascia, chronic changes. Well, there's nothing wrong with doing a cortisone shot in that as well. Or you want to make sure that the orthotic you're doing compensates for that as well, because they have compensated for so long. They have these combined problems for so long that you must treat everything you find. So if you find the plantar fasciitis, it still hurts on their heel when they walk after that test. It still hurts when you palpate it. Great. Treat that too.
Right. However, there are some cases where you'll find the primary generator and you take care of that, and the other ones just subsequently, body takes care of it. But yeah, you're right. If there's a musculoskeletal degeneration because of this process of compensation, you're probably going to have to take care of that as well. But
yeah, well, I have this thing on my phone where I'll stop myself in the middle of exam. It's like, you're going on the list.
Yeah.
Because I'll find something and we'll do a nerve block or we'll do an orthotic accommodation and suddenly like whew, the symptoms are improved. And I'll pause and say, okay, well, I'm going to add you to the list. So some examples of that, and be an expert at Zoom by the time I finish this. So
Well, if you are, I take my hat off to you because I've been using it for a long
I
time.
know
I still
it's kind
struggle
of
with it.
it's a moving target.
Yeah.
So this is what I call interesting patients. So I will expand this a bit so you can see this. So I get surprised all the time by things that work. So this patient broke her toe and it appeared to heal without incident. Can you see what I'm talking about? Can you see my screen?
Yeah, I see your screen very well.
So
Yep.
hopefully 6 months after her injury, her toe fracture, she started developing heel pain. And it was worse in the toe off phase of gait, which is, part of a gait exam that we would hopefully do. Cushioning the area that was symptomatic didn't help. X-rays of the heel were fine, but she had a nerve entrapment on the Scratch-Collapse test immediately adjacent to her fracture. So we took pressure off the nerve. I skip laced her shoe so that there was not a tight lace on the top of the nerve. And I put a pad, a Morton's extension, in her shoe that basically treated where the original injury was. And 80% of her pain was gone. And I like changed her shoe and her insert, and that was it
Yeah.
in just a moment. And then, this next patient had arthritis and x-ray showed moderate disease, but he had severe pain. Well, he failed a nerve reflex test for the nerve between the areas of arthritis. And in his case, we did a cortisone shot and metatarsal pad to take pressure off the forefoot. And, with the persistent arthritic joint, his pain went down 70%. So there's just, case after case, there's just so many things. So this patient had calcaneal fracture and had a lot of pain. And one of the few things that really gave him some relief was treating the deep peroneal nerve because he'd had basically severe damage throughout the entire foot. I have patients where we treated the nerve and within a few days, her scream and heel pain had improved. And she was already doing orthotics and all that too. So deep peroneal nerve is a really, really common one. It's not one that patients often complain. I have cramping on the top of my foot. But it's a really vulnerable spot. Shoelaces,
Yeah.
hand walker boot,
Yeah.
PK cast for a fracture. You take them out of the cast, and why do they still have pain? Why are they still, inverting their foot? Well, it's because they had a compression irritation from the deep peroneal nerve. I don't think this one's in here, but I have one where a patient had a first MP joint implant. And it was beautiful on x-ray, and the doctor was really happy with the result, but the patient was not. And so his physical therapist sent him over. First time he presented, he failed the test for the deep peroneal nerve, which makes sense. We just had this, joint at the first MP joint, or procedure at the first MP joint, and that seemed fairly logical to test for it out. I did a little nerve block in there in 2 weeks and orthotic adjustment. 2 weeks later, he wasn't much better. Still had a little bit of, we had quite a bit of resistance to motion of the joint. Gait was still compensating. He was not getting off this first MP joint, and it would look like the surgery failed, even though radiographically it was beautiful.
Right.
So it tested him again, and this time it was superficial peroneal nerve. Well, multiple ankle sprainer, been in the boot after surgery for some time, and probably got from those conditions some entrapment around the superficial peroneal nerve. Ultrasound will even show you sometimes where proximally the nerve is more elliptical, where the area of interest is. You'll see a little compression on the ultrasound, and then it'll be normal again, distal. So that wore out on ultrasound. And we just did the hydrodissection with local and steroid right at the area looks compressed until you see the fascia move away from the nerve. And a week later, he comes in, and his comment was, "You hit it out of the park." So basically now that first MP joint functions. He can move forward off of it. He can go back to doing what he wants. And it basically salvaged a perfectly done surgery.
Yeah, no, and that happens all the time. That deep peroneal nerve just doesn't have anywhere to go. You got a couple millimeters between the bone and the skin, and even if someone does a bunionectomy and they do a perfect dissection, just the swelling post-operatively can be enough to put that nerve into a problem. it's a nerve that just doesn't have a lot of forgiveness, and just anatomically speaking. But
You
no,
know,
that's a great point.
the anatomist that lectures a lot at AENS once described a very small capsular branch to the second MP joint
Hmm.
off of the deep peroneal nerve. Let me tell you how many times someone comes in to tell me, I have a second interspace neuroma, and I know that that's what that is, and it hurts right there, or they think they just have bursitis, and maybe they
Right.
have a long second metatarsal, and everything that you've done to help that has not worked. Keep in mind that there is anatomically a small capsular branch off the deep peroneal nerve. So I've had so many patients who fail treatment when it's approached as a second interspace neuroma because
Right.
no one was looking at this.
Right. No, that's a great point. What's one of the biggest barriers to entry? Because I mean, this is an important test. It's certainly a bullet that you would want to put into your armamentarium in the diagnostic world. Why? I mean, I know medicine's a slow boat to turn, but I mean, but we're looking at, 20 plus years here, or more. I mean, maybe less if you say it was published in 2009, 2010, whatnot. What's one of the big barriers to entry here?
I would say the doctors really need to spend time doing this, and if it can't be mastered in a weekend, then there's a little less acceptance of it. And unless you value this as something that can be the game changer that it is, it's hard to put in the time. Having said that, I've had someone learn it remotely, and
Right.
I've had people pick it up in a weekend. And the trick is really like making sure that you do the resistance test correctly. So what I've started doing, including with the doctor in Maine who learned this from me, is I will send some instructional information. So I have a Dropbox full of videos to show you the technique. So like anything else, you can watch this, you can practice, practice, and practice. You probably want to get pretty comfortable with it before you start injecting things. But it's really not that hard, and people perceive it as such.
Right.
So like anything else, if you're willing to practice it, you can get good at it. And I have condensed it down to where I can really teach someone how to do this very quickly.
Right.
So
So
that's the
basically, well, it's kind of like ultrasound.
yes.
When you make the commitment to put ultrasound into your practice, you're not an expert at the first day of that. In fact, you're probably not an expert on the 10,000th day. But the point is that you have to integrate these things into your practice so that you can become more adept at them.
Yeah, I do try to get some agreement. Like when I lecture on this, I'll try to, get one person in their community to be the expert at it. And I'm like, okay, I just need this one person in this community to
Right.
take this on and learn it because then they can teach it to other people who are interested. Not only that, I am the person in my community that gets these weird cases and this didn't work well and this surgery failed or they've had all this
Right.
therapy, nothing's working. I'm that person.
Right.
Well, you just need one person in that community and they can be your diagnostic go-to. And so
Right.
then I'll write back, I'll say, okay, you did a great surgery over here. I'm going to send them back with this simple little adjustment. Um, I'll send them back to their primary, say, okay, you need to do a spine workup
Right.
because it's not their foot.
Right.
So even if I can get one or two people in a community to be that touch point, it could help thousands of people.
Right. Well, it's kind of like I joke with my partner, Dr. Ducasse, and we're those ugly little fish that swim at the bottom of the aquarium that tries to clean up everything else. And most of the time, it's not because it's such rocket science. It's just because you have the eyes to look in that direction. And you can save these people a lot of heartache. And, a lot of times they're down the rabbit hole. They've had 15 MRIs and God
Right.
knows how many surgeries and all this other stuff. But then somebody looks in that one closet that's never been looked in, and it's like, oh, there you go. But I think the beauty about this is there's no capital expenditure for it.
This is true. And
Yeah.
sometimes I think that's one of the shortcomings. It's a skill, not a pill. So there's not like this, capital investment in training either.
Right.
There's not like this drug company or device company that's going to say, let's spend $50,000 on a seminar and da da da. So
Right.
there's really grassroots.
Right.
And it's acknowledging that there's part of the nervous system that's not getting checked every day, and you would no more ignore hemoglobin A1C
Right.
before surgery Why
Right.
would you ignore the postural part of the nervous system?
Right.
You know, we think
Well,
that there's
because
not,
you don't know about it. If you
you
don't
know,
know about it, it's hard to pay attention to it.
and after third year pre-med or second year physiology, you learn about these things, but if you don't have a tool to
Right.
examine that part of
Right.
the nervous system, it stays in the textbook.
Right. Well, and I think there's a lot of intrinsic value to things like this because when you're able to make a diagnosis and help somebody out, that is an immeasurable karma return that
Yes.
this is the juice of why we do what we do. And so I would encourage everybody to really look at this because they're going to get that feeling in the clinic like, wow, I just figured out something. That's a cool feeling, and then it makes that patient better. And that's even another cool feeling.
Absolutely. Because
Yeah.
everybody has that patient they dread. How am I going to fail to help this person today?
Right.
And
Exactly.
and
Yeah.
this overcomes that on a daily basis. And
Yeah.
the way that medicine is going, and it's so, compartmentalized and commoditized that, you can be a cog in the wheel,
Right.
or
Right.
or you can be the hub,
Exactly.
and you could be the reason why it keeps turning. And actually, you can set yourself aside outside of some of the constraints of the usual day-to-day mill because you've got this technique that not everybody else is willing to take on, and you're
Exactly.
going to solve a lot of problems. And so you're going to attract a lot of business and a lot of grateful patients.
Right. Yeah, no, it's wonderful. Karen, thank you so much. I love visiting with you on this, and I'm going to make a dedicated effort now to really start picking this up a little bit more because I think it really is kind of like some frosting for the cake, and so thanks so much. If people want to get a hold of you, what's the best way to reach out to you on your website or
Email, actually. So I'm going to put my PowerPoint back up. It's got that on there. Oh, I think
and I'll put it in the show notes as well so they can get to you.
Sorry, this is a new tablet. No. Okay, so there's my email. That's probably the best way. Oh, I'm not sharing my screen. As I said.
Zoom experts.
Yes, I know.
We are. Yeah.
By the time I'm an expert, I'll never need it again. It'll have been eclipsed entirely.
Yeah. I can learn something and then I have to relearn it a week later.
Right.
Right. Ah, there you are. Dr.
Okay.
Karen Anderson. Dr.
Dr.
K.
Kate Anderson.
Dr. K. Anderson. Okay, great. I'll put that in the show notes as well.
Great. Well, actually, it's been an absolute pleasure. I love visiting with you as well. And you can be my star pupil. I'll make sure you know how to do it.
Well, I'll try, but I think there's some very valid reasons why I want to get this into our day to day because I think it has a lot of merit and it could help us pick up a few things more. So I really want to thank you, and this was for me, it was very educational, and I appreciate it so much.
Well, thank you very much. I really, really enjoyed talking with you about this.
All right. This episode is sponsored by Savant Sellers, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Sellers. You may just never want to come out until it's gone. Savant Sellers sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at SavantCellars.com. That is CEVANT Sellers.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is the responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.